Good morning, everyone. Can you hear me? Excellent. It's my great pleasure to introduce Jason Lee today. Jason's an outstanding cardiology fellow who's been working with my group over the past several years. Jason received his undergraduate degree in chemistry from Cornell University and his MD from Boston University, where he won a number of accolades and awards. He then came out west, did his residency at USC, and his fellowship, obviously, here at the University of Washington. Jason is a passionate and dedicated researcher. His work with our group on fatty acid and cardiac arrest resuscitation outcomes has been outstanding. He's been invited to present his work in a number of venues, including the Medic One Paramedic Tuesday series, as well as the American Heart Association Council on Epidemiology scientific sessions. His work has been superb. And because of that, he was a finalist for the very prestigious, AHA's very prestigious Jeremiah and Rose Stamler Award. After graduation, Jason will join University of Massachusetts cardiology faculty as an assistant professor, where I am sure he will continue to do great work. Please help me in welcoming Jason. Please give him a warm welcome. He'll speak to us today about fatty acids and cardiovascular disease.
Thank you, Dr. Sodania, for that warm welcome. Good morning, everyone. It's my absolute pleasure this morning to present to you on Grand Rounds about the relationship of long and very long saturated fatty acids and their relationship with cardiovascular disease. My primary mentors are Dr. Nana Sodania and Dr. Rosen Lament. I have no financial disclosures. I think to get a better understanding of fatty acids, we have to go back in time and look at its history. The concept of fatty acids date as far back as to the usage and documentation of processed oils. We look back about 6,000 BC, and there was documentation of olive oil in modern-day Israel. 4,000 BC, you have palm and coconut oil in Egypt. And thousands of years later, 1000 AD, you have soybean oil documented in China. However, the knowledge of the chemistry of fatty acids didn't really mature until the mid-1800s, where they shifted from mechanical processing of oils to chemical extraction methods. It is another 100 years later before the idea of saturated fatty acids leading to cardiovascular disease surfaced with the help of this gentleman on the far right by the name of Dr. Ansel Keys. Through his seminal work on the 7-country study, he proposed that saturated fatty acids lead to cardiovascular disease. And he did this through looking at populations of these people living in the countries, assessed what they ate, and looked at the incidences of cardiovascular disease. It took another few years where he noticed through his travels that in southern Italy, they had the highest distribution of people living to the age of 100 or more. And he looked at the diets and he coined the term Mediterranean diet from these people. Fatty acid structure and how they bond in the body and usage is shown here. If you attach a fatty acid, 3 of them actually, to a glycerol, they form triglycerides on the far right. If you have 2 fatty acids formed to the phospholipid hydrophilic chain head, you have a phospholipid helping form cellular membrane. So fatty acids serve both as cellular structure and also as energy in our human bodies. The categorization of fatty acids can be done in one of 2 ways. One is how many double bonds that they have. So if you have a saturated fatty acid, for instance, starting off on the far right over here with a left of carbon-connected hydrogens and extending all the way to the end of the carboxyl group, if it has only single bonds for all the carbon chains throughout, then that's a saturated fatty acid. If you happen to have anywhere a double bond, then it's labeled as a monounsaturated. And if you have more than 2 double bonds, it's a polyunsaturated fatty acid. And that's where more of the ones well-studied and well-known omega-3s and 6 are in the categories. You can also label fatty acids according to carbon chain length. Shown here, saturated fatty acids, if you go from beginning to end, if you count the number of carbons, let's say hypothetically that's 14, it's labeled as 14O fatty acid. Shown here is common oils on table format. Starting off at the top, you have coconut oil. As you go down the table, you should appreciate that there's a lower percentage of saturated fats and a higher percentage of mono and polyunsaturated, going all the way to canola oil. And I know what many of us are thinking right now. What did I buy at Costco many months ago, store away on the shelves? It must have been canola oil, not coconut oil, is perhaps what we're thinking. And really the reason for that is because of this concept that Dr. Ansel Keys proposed back in the 1950s, shown simply here by happy faces and happy faces. So in our minds, we really associate saturated fatty acids as being bad, shown in red. And as you have apparently more double bonds, the happier you are. Kind of like a fact in life, the more things you have, maybe the happier you are. But I want to challenge that paradigm in this talk today by showing you evidence that not all saturated fatty acids are the same, and that we should actually break them down even more and look at them in detail. And I propose that very long saturated fatty acids, which have 20 or more carbon chains without double bonds, they have association and potential causal association with improved cardiovascular outcomes in terms of incidence and after you develop the disease. Now, saturated fatty acids altogether, perhaps at the lower end of the carbon chains, should deserve the reputation that's shown here. In this talk, I want to scaffold our understanding with polyunsaturated fatty acids as well, showing studies there just because it's more commonly known in order to help us better understand everything. And through that, I also want to propose that the way that you supplement polyunsaturated fatty acid matters. In a sense, if you're eating it through natural diet, such as fish, you have a different outcome versus supplementing it through medications. Let's get started. Long saturated fatty acids, as briefly mentioned, can be categorized according to carbon chain length. Shown here are the three most common ones, 14O, 16O, and 18O. 16O, otherwise known as palmitic acid, is the most abundant fatty acid in our diet. And if you eat anything with fat at all, it's guaranteed to give you a shot into your bloodstream. What's also been shown is that if you consume higher levels of these long saturated fatty acids, you're going to have an increase in your LDL. Through prospective observational studies, it's shown that higher levels of these fatty acids leads to higher incidence of cardiovascular disease that I'll highlight later. If we look at very long saturated fatty acids, these are carbon chains of 20, 22, and 24 being most common in our circulating blood. They portend a different story. They're found commonly in peanuts and canola oil, and they're consumed by diet, but also could be made endogenously through elongase of 16 and 18O. And through prospective studies, they've been shown to lower the incidence of cardiovascular disease. The mechanism of action is still not known, but it's proposed of one or two ways. The first is very long saturated fatty acids interact with sphingomyelins and go to the cellular membrane, form lipid rafts shown here. Through lipid rafts, these are known to perhaps stabilize the cellular membrane when the cellular damage and apoptosis. Another mechanism is through its interaction with ceramides, what's known to slow down apoptosis. With these two mechanisms, we do acknowledge that higher levels of very long saturated fatty acids do slightly increase LDL. So whether or not the health benefits are shown through the other two mechanisms, at least the side that shows the detriment of having higher LDL is less at play compared to two other mechanisms at hand here. Here I want to highlight that the most common fatty acids are 14O, even chain numbers. And that's why I'm showing 12, 14, 16, 18, and so on. And these are the dietary sources that you're able to see where they're mostly from. And I emphasize that, again, 16O comes with all fatty foods, including the burgers that you're eating and the pizza that you're eating. And that the very long saturated fatty acids mostly come from peanuts and canola oil. Polyunsaturated fatty acids have double bonds in them, as mentioned. The two most common ones that are studied that show health benefit are EPA and DHA, shown here. Their mechanisms are well studied, and through different diseases, these are the hypotheses. For coronary artery disease, the hypothesis is that they lower LDL, triglycerides, and promote HDL. They also lower the active inflammation in the body. For arrhythmias, it's known to stabilize the cellular membrane and perhaps increase the membrane threshold potential. And for heart failure, it's known to decrease myocardial fibrosis and promote healthy LV remodeling. With that, I want to go into the first disease that we're to talk about today, coronary artery disease. Globally, it has a huge prevalence of over 315 million cases in 2022, done by a study by Dr. Greg Roth. It's a leading cause of mortality worldwide. And in the United States itself, you can see the prevalence and incidence increasing across time. In fact, across all age groups shown here by the year 2050. And hence, it's imperative that we find new markers, perhaps biomarkers such as very long saturated fatty acids, and better understand the disease and seeing if there's ways we could affect incidence and outcomes. I'm going to highlight a lot of studies now for coronary artery disease. The first one is detailing association of saturated fatty acids with incidence of coronary artery disease. This was done on over 120,000 patients, combining the nurses' health study and the health professionals' follow-up study. They had a total incidence of 7,600 cases of coronary artery disease. And what this study did was through questionnaires of asking what the nurses and health professionals took in, they proposed that if you kept the calories the same in the daily intake, but substituted the saturated fatty acids with healthier fatty acids, such as monounsaturated fatty acids and polyunsaturated fatty acids, would there be a lower incidence of disease? And what they found was if you did do that, you have a 15% and a 25% relative lower risk of having coronary heart disease at the end of their study. On a more granular analysis, where they looked at individual saturated fatty acids, in a similar population, although the numbers were different just because of what data was available, there was over 7,000 incident cases of coronary heart disease. And what they show here is that if you substitute 1% of total energy, replacing polyunsaturated fatty acids, the omegas, healthy ones, with the less healthy long saturated fatty acids, 16O, and also if you combine them as a group from 12, 14, 16, 18, then you have a significantly lower percentage incidence, about a few percentage to 10% lower incidence of coronary heart disease. Similarly, if you replaced it with whole grain carbohydrates, you had a similar finding, and with plant protein as well. If we shift over to very long-chain fatty acids, and these are the healthier ones, there was a nested case control study done also from the two cohorts, Nurses Health Study and HPFS. There was about 790 incident cases of coronary artery disease, matched to over 1,200 case-free cases. In this pooled analysis, what they showed of all three fatty acids, 20O, 22, and 24, was that if you had the highest quintile level of these fatty acids compared to the ones who are the lowest, you had a 52% lower risk. 52% lower risk of developing coronary artery disease. Now, I know what many of you are thinking. I've just shown you the same trials in terms of the same cohorts, same cohorts and studies in the Nurses Health Study and health professionals. I do want to show a different one, showing from a different cohort of patients. It was a case control study nested in the PREDIMED trial with 136 coronary artery diseases and 272 controls. Here they measured red blood cell levels of our very long saturated fatty acids. What they showed was for each standard deviation of increase in 22 and 24 very long chain fatty acids, there was over 50% lower incidence of coronary artery disease. Now, what about polyunsaturated fatty acids? There was actually 3 really well done randomized controlled trials starting in the 60s up to the 70s. The first one I highlight is the VA study done in LA, where they studied 846 men, with 30% of them having coronary heart disease already, with a mean age of 65. And what they did was they randomized their patients 1-to-1 to the experiment and to the control. The people in the experiment were supposed to replace, and they did, most of the saturated fatty acid diet with polyunsaturated fatty acids, majority of which was the linoleic, one of the omegas. And what they show here in table 1 is the composition of diet. In control, patients had far higher cholesterol and lower linoleic acid. In the experiment group, they had lower levels of cholesterol and higher levels of linoleic acid. As a proof of concept, they drew blood from these patients and did find that throughout the trial, they had lower serum levels of cholesterol in the experimental group. At the end of the trial, with a greater than 8-year follow-up, they showed that patients who were eating the substitution of higher polyunsaturated fatty acid diet had a lower incidence of coronary heart disease. This was replicated in the Oslo heart study, done a year later on 412 men aged 30 to 64, and it was a higher risk population that patients enrolled in the hospital after their first heart attack. And they did similar things where they replaced their main saturated fatty acid with polyunsaturated fatty acids. And by drawing blood, they showed that patients in the experimental arm had about a 14% reduction in cholesterol overall. At the end of the 5-year study results shown here, we could appreciate that there was lower cases of a relapse of coronary heart disease. There was actually also lower cardiovascular mortality and total mortality with the group in the control arm. They actually stopped following these patients so closely after 5 years and just let them go into the community without drawing blood, without clinical visits. But they did have follow-up at 11 years. And as shown here, even in the diet arm after 11 years, there was still significant difference here in terms of rates of fatal MIs. Those 2 studies were predominantly men, in fact, all men. So I want to highlight a study that included women. It was over 50% in the Finnish mental health study done at psychiatric hospitals. This study design was particularly interesting in that there was 2 hospitals that they enrolled patients. The first one that they did, they put the patients on a particular diet that was higher in polyunsaturated fatty acids for 6 years. And at the other hospital, they enrolled patients under the normal diet they were eating. They did a crossover at the end of 6 years. Shown here, patients actually had serum cholesterol reflecting the change in diet. The patients who were enrolled in the healthier diet had a lower serum cholesterol. And as we can appreciate, when they shifted over the diets, they had a high cholesterol. And the other arm, who were in the control initially, becoming experimental later, they have a lower level of cholesterol. And what this study did was they looked at basically comparison of these patients while in the period of the healthy diet, did they have a lower incidence of cardiovascular disease? And indeed, they did across men and women here. In fact, perhaps lower than 30 to 40 to 50% lower risk of having coronary heart disease at the end of their study. So now I've shown you coronary artery disease. I want to move on to the next disease, atrial fibrillation, which also has a high incidence and prevalence. Incidence back in 1990 has been quoted about 2 million a year. It's grown to 4.5 million almost annually in 2021. And we could appreciate the trend of incidence here. It's estimated that by 2021, there was a prevalence of 52 million cases of atrial fibrillation. In our country itself, by 2030, it's estimated there's over 2 million annual cases of atrial fibrillation. And prevalence could be quoted as high as 10 million in this country. And hence, it is also important to look at biomarkers to associate incidences of this disease to get better understanding. Surprisingly, there's a lipid paradox going on with incidence of AFib and fatty acid levels. If you have a lower LDL, lower total cholesterol, through multiple studies out there, it's been shown that if you have this, you have actually a higher incidence of developing atrial fibrillation. And the mechanism is yet to be discovered. When we look at unsaturated fatty acids and polyunsaturated fatty acids, we do see that the incidence falls in line with what we talked about coronary artery disease. In a study done in the cardiovascular health study with over 3,300 patients with 700 incident cases of AFib, what this group did was they expressed EPA and DHA as a percentage of total fatty acids and did this multiple spline regression, showing incident risk of developing atrial fibrillation as this percent levels went up on this cohort. And you're able to appreciate that there was a trend as higher concentrations or percentage of EPA was in your total fatty acids, you had a lower incidence of developing AFib. For DHA, it was significant. And the combined, all 3 of these fatty acids, EPA, DPA, and DHA, you did have a lower incidence of developing atrial fibrillation if you had higher percent levels of these in your plasma phospholipids. However, if you're supplementing this, not through diet, but through medications. These four are some of the main trials done to find associations with lower cardiovascular disease with supplementing polyunsaturated fatty acids, more so the omega-3s. We're seeing a different story. With the STRENGTH trial, which had a formulation of EPA and DHA, and you look at down the line, there's a dose response in how much you're supplementing. STRENGTH and REDUCE It had 4 grams per day versus OMI and VITAL, which is far less. And if you had a 4 gram per day supplementation, whether it's only EPA by itself, you had a higher incidence that was statistically significant of developing atrial fibrillation. So it's not just all a smiley face here going on for our story. If you supplement it, there's actually negative side effects. Now, what about long saturated fatty acids and very long saturated fatty acids? Our group performed a study on the cardiovascular health cohort with over 2,800 cases of patients without AFib. And it was a 700 cases of incident AFib with an 11.2 median year follow-up. And what they showed, expressing 16O here on long saturated fatty acids as a total percentage of fatty acids and dividing it to median, if you have higher levels of 16O, which is bad, you have a higher risk of developing atrial fibrillation, about 27%. If we move on to the very long saturated fatty acids, which has a healthy benefit, we're able to appreciate that for 20O and 22O, if you're above the median compared to below the median, you had a lower risk of developing less than 25% chance, lowers the risk by 25% chance of developing atrial fibrillation. And this was stratified according to age. When they combined the stratifications and took that away for less than or greater than 74, this also remained true for these individual fatty acids. Now let's move on to heart failure, which has pretty high prevalence incidence as well. And mortality, sadly, still remains very high despite modern treatments and advancements. In the United States itself, it's calculated perhaps that 7 million Americans 20 years older have heart failure. And there's some studies that propose that 1 in 4 of us will have heart failure at a certain point in our lives. So I want to take a look at polyunsaturated fatty acids in relationship with incidence of heart failure, done here in over 6,500 patients with a 13-year follow-up and 292 cases of developing heart failure, including reduced and preserved. And this was similar in that it was looking at percent of EPA and DHA. And what you're able to appreciate here is if you have higher percentages of your EPA and DHA in your body, then you have a lower incidence of developing heart failure, including a combined percent EPA and DHA here. I want to highlight a few studies that looked at outcomes of patients who already have heart failure. In a meta-analysis of 14 randomized controlled trials with heart failure patients, they show that if you supplemented omega-3 fatty acids at a dosage of 2 to 4 grams per day, patients not only had improvement in LVEF, but objective improvement in exercise with peak VO2 values as well. In the JEST-CHF trial, there was a randomized controlled trial where they assessed if patients taking 1 gram omega-3 fatty acids were control with a median follow-up 3.9 years, if there was a difference in cardiovascular outcomes. And indeed, they've shown that in that patients who have heart failure, if they were supplemented with 1 gram omega-3 fatty acids, they had a lower reoccurrence of cardiovascular emission and also cardiovascular death. Moving on to saturated fatty acids, looking at long-chain saturated fatty acids with 14O, 16O, and 18O, in this ERIC subset of 3,500 patients with a median follow-up of 14 years with 197 incident cases of heart failure, after adjustment for age and sex, we're able to appreciate that there was a statistically significant increase in incidence of heart failure for higher levels of 14O, 16O, and 18O. If we look at very long saturated fatty acids, it's a different story again. With over 4,200 patients, with 45,000 person years, and 103,000 incident cases of heart failure, our group was able to show that if you have a higher level of 24, 22, and 20O shown in green here, which includes both HFrEF and HFpEF, you have a lower incidence of developing heart failure. And this remained true for the subset of HFpEF for 22 and 24 levels. The last disease I want to highlight carries a high mortality, sudden cardiac arrest. Annually around the world, there's estimated 4 to 5 million cases occurring. And it's the leading cause of mortality in this country with over 300,000 cases a year. There's limited therapies despite well-established ways to treat patients, including CPR, defibrillation, and targeted temperature management. And hence, even in sites with very robust health facilities and paramedic care, the rate of mortality is quoted as high as 50 to 70%. And if you're out in other parts of the country, it's quoted as high as 90 to 95%. So we could do better in terms of figuring out how to treat this disease. Here I want to highlight a case control study that looked at the incidence of sudden cardiac arrest with long saturated fatty acid levels done here in King County. Dr. Lamette and Dr. Sodinia led the study where we looked at 16O fatty acid levels, and that if you had higher levels in the red blood cell membrane, for each standard deviation increase, you had a 28% associated risk of developing sudden cardiac arrest after adjusting for age, gender, physical activity index, and BMI. If you did additional adjustments for omega-3 fatty acids, you had a 38% increased incidence of having sudden cardiac arrest. Now we shift gears again to looking at very long-chain saturated fatty acids, and we're seeing another favorable story. In the same patient foundation of 265 sudden cardiac arrest cases matched to 415 controls, we're able to appreciate that for 20, 22, and 24, across the two models that were just similar to the previous study, we're seeing a lower incidence in patients who have higher levels of 20, 22, and 24 at the highest quartile compared to the lowest quartile. In fact, it was almost 40 to 50% lower risk of developing sudden cardiac arrest. Polyunsaturated fatty acids also carry a similar favorable trend. In this nested control study done in the physician health study with 94 sudden cardiac arrest cases and 184 matched controls followed for 17 years. Shown here is there was at least a trend of patients who did have sudden cardiac arrest having lower EPA levels, and there was a statistically significant lower level of DHA for patients who had sudden cardiac arrest compared to those who did not. And in multivariable analysis adjusting for similar covariates, what they show was for patients with the highest quartiles of polyunsaturated fatty acid levels, there was almost over 80% lower incidence of developing sudden cardiac arrest. One study actually looked at supplementation in terms of naturally eating foods such as fish and seeing if it improves outcomes. And fish has been associated with raising higher levels of omega-3s. Done in the physician health study with over 20,000 patients, incidence of 133 cases with 11-year follow-up. And what they found was men who ate fish greater than once per week, compared to those who ate fish less than once monthly, had about a 52% lower risk of developing sudden cardiac arrest. Now that I've shown you the incidence of sudden cardiac arrest, I'm very excited to show you what happens if patients develop sudden cardiac arrest. And through our work with Dr. Sodinia and Dr. Lamette, we took a cohort of over 1,300 patients in the CAPS registry who were 18 years or older, had VFib as incidence for sudden cardiac arrest, and had blood collected at the field and time of cardiac arrest. We looked at 6 fatty acids, 14O, 16O, 18O, 20, 22, and 24 for very long saturated fatty acids, and grouped our patients of 1,300 into those who were discharged alive, those that died in the hospital, and those that died in the field. What we show here is that patients who are surviving sudden cardiac arrest, as in discharged alive, they tend to be younger, less likely to be men, and have more favorable sudden cardiac arrest characteristics, including less likely being found at home, more likely to be in public, and more likely to have witnessed arrest and receive bystander CPR and shorter EMS times. When we did a multivariable Poisson regression analysis to look at association of long saturated fatty acids with outcomes of sudden cardiac arrest, shown here in this figure, to the right portends better prognosis. And for purple, we have hospital admission rates, and for the green triangle, we have discharge alive. And to put it simply, hospital admission means that you survived sudden cardiac arrest, at least to the point of coming to the hospital. Apologies, I should explain it as you've achieved cardiac resuscitation, as in you received enough CPR and made it to the hospital, got admitted, but you may not have brain resuscitation. And so if you incorporate cardiac resuscitation and brain resuscitation, then you have being discharged alive as a primary endpoint that we investigated. What we show here is that for every standard deviation increase in 14O levels relative to the total percent fatty acids in your blood, there was a 14% lower incidence of surviving sudden cardiac arrest after adjusting for multiple comparisons. We did not find this association with 16O or 18O. If we move over to very long saturated fatty acids, we see that for 20O, 22, and 24, for all three fatty acids, there was at least a nominal association of improved survival after sudden cardiac arrest. And after adjusting for multiple comparisons, 20O levels remained statistically significant. There was a 18 and a 12% respective higher rate of survival after sudden cardiac arrest. With that in mind, we sought to investigate if 20O levels could have causal association. And to do this, we performed a two-sample median randomization. First, looking at the Charge Consortium over 7 cohorts composed of 10,000 individuals of European ancestry, where we had rich genetic data. There, we found 3 GWAS significant SNPs, shown here, and used them as genetic instruments, applied it to our CABIS registry. And what we found was pretty exciting, in that for every standard deviation increase in genetically predicted 20O levels, there was an 84% causal associated improved survival from sudden cardiac arrest, at least through Mendelian randomization analysis. So conclusion of our study is that higher levels of very long saturated fatty acids, more so 20O, and lower levels of 14O red blood cell level associated with a higher improved survival from sudden cardiac arrest. Through Mendelian randomization analysis, we show that there's a potential causal association with the relationship between 20O and sudden cardiac arrest. The mechanism still needs to be studied, but could be one of the two that we proposed earlier in our talk. I want to finish our talk with one more point, and I want to refresh our memories with the 3 randomized controlled trials that we had back in the 1960s. It was well designed, and for good reason. What they did was they replaced the saturated fatty acids with polyunsaturated fatty acids as a diet mix-up. So we're very confident that perhaps treatment can be with diet replacement. However, I do want to highlight a trial that did things differently, and you're not seeing the same results. In this study of Women's Health Initiative, over 48,000 women, postmenopausal, they randomized these patients to a low-fat intervention versus control with a 6-year follow-up. And these patients did have, in the experimental group, indeed lower saturated fatty acid intake. So that was good. However, they were supplemented, as you see here, in that the polyunsaturated fatty acid levels were actually not higher compared to the control. Instead, the dietary carbohydrate levels were higher. And because of this, they did not have any associated different outcomes at the end of the study. So what you supplement in terms of natural diet matters, is what I'm trying to prove a point here, in that you should really supplement with healthier fats and not just refined processed carbohydrates in the study. One final statement on medication-based replacement therapies. Many of us know about the Reduce-It and Strength trial. Reduce-It trial did show a positive finding when they used mineral oil as their control. And they showed that at the end of the study, there was a 25% lower incidence of ASCVD risk in this population that had higher triglyceride levels, and it's been approved for FDA use. In the Strength trial, however, when they used a formulation of not only DHA, but a combined DHA and EPA, there was no associated difference in outcomes. And this is actually largely true for most of the trials, where some would argue perhaps Reduce-It was a false positive finding. So summary of saturated fatty acids is that higher levels of long saturated fatty acids associate with a higher incidence of cardiovascular disease, such as CAD, AFib, heart failure, sudden cardiac arrest, and portends to worse cardiovascular outcomes. Higher levels of very long saturated fatty acids associate with a lower incidence of cardiovascular disease, and as is shown here, improved survival from sudden cardiac arrest. So now going back to the beginning slide was very simple. How do we feel about saturated fatty acids? And I hope that I've somewhat convinced you and nudged you in the direction to change the paradigm shift on thought that not all saturated fatty acids are the same. Perhaps we should come in with a neutral face in that very long saturated fatty acids are actually having favorable outcomes and agree with you guys that long saturated fatty acids do portend to unfavorable outcomes. If we look over on polyunsaturated fatty acids, while the story may be rosy, I do want to give a word of caution in that replace actually taking in omegas through eating high levels of fish is favorable, and it's been shown through many studies and even randomized controlled trials. If you're replacing with pill form, besides reduce-it trial with purified EPA cosapentyl ethyl, largely a lot of the medications did not work. In fact, you had a higher incidence of atrial fibrillation on secondary analysis of these trials. So I think this is somewhat of a neutral thing with the medication yet to be seen, what happens later on as well. And I think the AHA, ACC guidelines have incorporated this finding. Throughout history, actually, if you go back to the 1960s, as Dr. Anselki proposed the diet heart lipid disease hypothesis, the AHA has taken a stance to tell everyone, please reduce your saturated fatty acid intake. And even in 2013, they stipulated how much percentage of saturated fatty acids you should have in your diet. And I'm pretty guilty. I probably would never get 5 or 6%. But after this talk, I both convinced people to think twice before going to Burger Master. If we look at 2017 and 2019 on the guidelines, there's a shift a little bit in terms of mellowing out of the stance in that they write you minimize the consumption of saturated fatty acids. And if we go forward now, a year later to 2020, with an ACC review, I think this is the direction perhaps we should head towards, in that we shouldn't just bucket saturated fatty acids as a whole as unfavorable and detrimental, but instead look at food groups differently, in that some studies have shown whole fat dairy, unprocessed red meats, and dark chocolate does not actually increase or decrease cardiovascular disease or risk, and hence perhaps we should incorporate food-based recommendations in the future guidelines. I want to conclude our talk by reviewing what we learned here today. The observational studies and randomized controlled trials show that with a lower intake of saturated fatty acids and a higher intake of polyunsaturated fatty acids, it's associated with a lower rate of cardiovascular disease. There's a difference in association of long saturated fatty acids and very long saturated fatty acids with cardiovascular outcomes, including CAD, AFib, heart failure, and sudden cardiac arrest. And there is indeed a difference in sudden cardiac arrest outcomes with varying levels of long and very long saturated fatty acids. So I do recommend that perhaps it is worth noting we should be cooking with canola oil, eating peanuts, putting peanut butter on our jelly sandwiches to raise our very long saturated fatty acid levels, and continue eating fish in order to promote healthy intake of omega-3 fatty acids to lower incidence of developing cardiovascular disease. Future directions for very long saturated fatty acids could involve similar things that was done for polyunsaturated fatty acids, and that perhaps we could supplement patients' saturated fatty acid intake with very long saturated fatty acid intakes. And coronary artery disease should be a primary endpoint because of the prevalence incidence of the disease that you need less patients enrolled. If we are to look at medication therapies, similar to what omega-3s are, I think we should keep in mind that not all omega-3s were showing positive trends with medication supplementation. Perhaps in a subset of very long saturated fatty acids, that could be the case as well. Perhaps maybe only 20O is coming out significant down the line. With that, I want to close and thank my mentors, Dr. Nana Sodania and Dr. Rosalind Met, for the stellar mentorship and supporting me in my research and on this talk and many other talks. I want to thank my team, Jen, Carrie, and Lee, on their help, and our fellowship faculty, Dr. Rose Freeman, Dr. Kelly Branch, and Dr. Alec Mormon, and my dear and beloved mentor, Dr. Jim Kirkpatrick, who mentored me a lot throughout fellowship. I want to thank the fellowship staff as well, Teresa, Erica, and Savannah, and my wonderful co-fellows who supported me all the way and been there, and my lovely family as well. Thank you for your time, and happy to answer any questions.
Jason, fantastic talk. What a tour de force. I'll open it to questions, and Farid.
Jason, that was fantastic talk. I have a question about your own data. If I understand correctly, alive was different than hospital admission, right?
Correct.
So does that mean that we should think about effects on the brain here? Because cardiovascular, or in terms of getting rhythm back and whatnot, there's patients did fine. So I didn't see anything about brain health here. Is there any association and
Yeah,
stuff with brain disease?
that's a,
Maybe you said it and I missed it.
you hit the nail on the head. I kind of pushed that aside, and when I did a talk focused on our sudden cardiac arrest study, we focused more on brain health. Indeed, a brain resuscitation was the marker that came out significant more than cardiovascular. So in the sense of resuscitation to make it to the hospital, it didn't matter as much in terms of your very long saturated fatty acid levels. Um, but it did matter after you got admitted to the hospital and came out alive. And so that's where we show that in discharge alive here, these are the patients who survived both cardiac and brain resuscitation. There was a statistically significant mechanism. So perhaps it pertains to saying, you have this window for patients once they're admitted to harbor review after starting cardiac arrest, and perhaps you could somehow increase the very long saturated fatty acids then, or perhaps beforehand, having them taking higher levels of peanuts and canola oil. And I didn't highlight this, but there is a lower incidence of neurological disease such as stroke and dementia if you have higher levels of long saturated fatty acids. Sorry, did I confuse that? The higher rates of stroke and dementia with higher long saturated fatty acids. And then if you have higher very long saturated fatty acids, you have a lower incidence of those diseases. So that's a very good point, Dr. Patel.
So Jason's talk here focused on cardiovascular disease very nicely, but you're absolutely right. Consistent with his findings, and partly that's what motivated his hypotheses, that long chains are bad for the brain and very long chains are good for the brain, which is exactly what he found. So really astute question. Yeah, go ahead.
Do you think that the higher stroke level and higher neurological, worse outcomes are due to what? Is there more patients with that have more AFib or conditions that make you prone to having stroke?
Yeah, that's a great question, to be true. And I didn't show this, but we did adjust for known cardiovascular disease, including AFib, heart failure, on patients who actually were admitted to the hospital. So that's about 650 patients we adjusted, and there's no difference in terms of the beta coefficients for outcomes. But the mechanism is still unknown, but I sort of postulate a little bit, and I do believe perhaps it has to do with very long saturated fatty acids interaction with sphingomyelins and ceramides and stabilizing the cellular membrane after damage and disease, shown here, where perhaps it provides membrane stability so cells don't die as much, along with interaction with ceramides is the leading thought from a lot of the publications. Cooper.
Really great talk, Jason. I'm curious how your very in-depth understanding of fatty acids has influenced your clinical practice. I think we as clinicians are undertrained and under-resourced to give dietary recommendations, but in your clinic with Dr. Branch for your primary and secondary prevention patients, what are you counseling them on, and does it go beyond the Mediterranean diet? Because that's sort of where I get hung up, or that's the extent of my knowledge.
Yeah, that's a great question, and I'm very guilty that I don't think I spend enough time in my clinic with Dr. Branch about advising primary prevention through diet and exercise. And actually, I wasn't super confident promoting intake of canola oil and peanuts up until actually looking at all the studies. Because for the years I've worked on the study, I've only focused on one, and now that I've been forced to look at grant rounds, looking at all the studies, it's a pretty good, robust area where I'm now confident, I think, in my clinic to tell people, hey, instead of cooking with coconut oil, which you shouldn't do, perhaps you should substitute with canola oil, and that putting peanut butter in your jelly sandwiches could really decrease your risk of developing cardiovascular disease. So I'm pretty confident after doing all this literature search that if I give this recommendation, it is with a lot of substantial evidence. And in terms of fish intake, what I saw for polyunsaturated fatty acids, I would recommend eating fish when we can. And we're lucky to be in Seattle with ample salmon. And we exercise so much in Seattle that sometimes I don't have to counsel patients on exercising more. So that's a great question, Cooper.
Jason, can I make another comment maybe or get your opinion? I think we should be careful about randomized studies from the 60s where there was no other treatment for coronary disease, right? I mean, nothing can beat statins. Do you agree? Like if you do that trial now, I would be very shocked if it comes out as having a favorable outcome. What are your thoughts?
Yeah, that's a very good point, Dr. Pasavi. Yeah, in 1960s, 1970s, we didn't have all the intervention, also the treatments in terms of medications. But with that being said, by itself, it's showing these are well-designed trials in the 60s and 70s. And if you can derive a benefit that's there from just diet, and actually I do want to bring up, not all patients take statins after you recommend them to take statins. So I think there's still a subset of patients that would really benefit, who are really resistant to perhaps Western medicine and more for naturopathic. They come to our visit for some reason. I've seen a lot of these patients. They're like, I don't want to take a statin. I am going to go to my naturopathic doctor even after listening to you. And I think so perhaps you have another avenue to target and recommend that's more palatable to them, food for thought for them to take in on that part.
One more question for you before we go to the online questions. I was really curious about the atrial fibrillation paradox, and there's a paradox in many ways. One is the LDL paradox, the cholesterol paradox, and I think it's more actually, if you look at it, it's more U-shaped or upside down U-shaped. It's really interesting. But I was interested in the supplementation. When you supplement PUFAs for AFib, you showed straight up every study higher risk of AFib. But when you supplement PUFAs for heart failure, you have improved outcomes.
Yeah.
And Gissi Prevenzione, which is a kind of a sister trial to the Gissi heart failure, also showed improved outcomes for sudden death, for example. You'd think that if heart failure is improving, AFib would be decreasing. Why do you think we see such funky results?
Oh, that's a phenomenal question. I actually
answer.
don't really know at all. Yeah, maybe perhaps with one thought would be the arms that polyunsaturated fatty acids, PUFAs, help each of these disease states, and just hypothesis, perhaps it does more for the heart failure side, and then there's some unevenness in terms of balancing the cell membrane stabilization and whatnot. We do know actually that the percent composition of fatty acids, very long saturated and polyunsaturated in intracellular membrane, and perhaps in the cardiac cells that develop arrhythmias in the heart, if those compositions change with diet and perhaps supplementation is what the trials are showing, then perhaps you have different action potential. So that's perhaps one thought that's there, but I don't think anyone studied the exact mechanisms, but that's a great question you proposed.
Thank you. Just really interesting field of work here. You have a couple of questions online. Malish says, nice talk. What's the effect of fatty acids on CRP and other markers of inflammation?
Yeah, so CRP, a marker of inflammation, long saturated fatty acids have been shown to raise LDL, and they also increase CRPs. I tend to forget if actually what happens with very long saturated fatty acids. It increases LDL as well, but I don't remember on the back of my mind, and I can look it up later and get back to you on whether CRP levels are increased with very long saturated fatty acids.
One more question from Rashid. Great talk. Does it matter which fish one eats?
Ooh, I wish I looked into it more. But from the assumption of that you want PUFAs, polyunsaturated fatty acids, perhaps the fatter the fish, the better. And salmon doesn't hurt here in Seattle.
And you're exactly right. People have looked into fried fish versus fatty fish, because fatty fish you tend not to fry, whereas less fatty fish you do tend to fry. And fatty fish give you the health benefits, whereas fried fish don't. So great question. Any final questions from the audience?
Andrea?
Andre?
Yeah, that's a good question. I don't know if there's a hypothesis on why, just because your question sometimes it's similar to Dr. Sodania's in that if you're supplementing, why is there benefit for heart failure, but then you have high rates of AFib? Yeah, that's a tough one to answer in a sense, but that's a definitely a question to study in the future. Thank you.
With your chemistry background, maybe someday.
Right, exactly.
With that, thank you everyone for coming and really wonderful, wonderful talk. Wonderful.
Thank you.